Yes, the PHQ stands for Put It Here, Cutie. Not really. It's the Patient Health Questionnaire 9, as in 9 questions. And I'm thrilled to be here. I'm so proud to be from Oregon. In this past year, we've just done more and more to bring maternal mental health to the forefront and to be able to really include screening for maternal depression through home visitors is kind of a dream that I never really thought would happen anywhere. And to have it be in our own home state, it makes me really proud. I get to talk to lots of people from lots of different states and countries, and they're kind of impressed. So, put it here, cutie. We are ahead of the game. Now, in part, that means you're pioneers, and when you have questions and you're not sure how does this work, or am I even scoring it right, or you know, is this effective? That's because you're on the learning curve. So please don't worry. First, absolutely don't worry if you can't remember how to score at the end of this session. It is an objective, and I'll teach it to you. But that you can learn and relearn. Honestly, what I really feel is important and is the potential of each of you is to be able to reach moms and dads and families with compassion, without judgment, with your heart, and a little scoring to screen if they're depressed or anxious helps you in that process, but it's not the only part of the process. So when you get confused and you think, like, okay, on top of learning all this, now she's asking us to add and multiply, please don't worry, because that part can be practiced. The learning objectives for this session, and we have 2 hours. I will do my best to use adult learning techniques and have you have breakout and learn to play with, play a little bit with the scoring and talk to each other in the middle of it. And I don't believe you have a scheduled break, so we'll do our best to is that right? No break. Okay. You have a break at 2:30. I thought I'd start with this. Maternal depression is the #1 most common complication of childbearing. More common than preeclampsia, gestational diabetes, cord prolapse, and yet is it the most common complication that we talk about? Do we learn about it? And that's the problem, because if something is so common and yet never talked about, that's a formula for what? For a taboo, for shame. When a long time ago, in a galaxy far away, I had my first child, almost 18 years ago now, and I had already been a therapist for 14 years. I had a PhD, and I had learned nothing about postpartum depression. He taught me everything I know. And he's a beautiful boy and a success story. We call him the poster child. My second child I had 3 years later, and I did not have postpartum depression or anxiety. Not because I'm better than someone else who had it, not because I prayed the right prayers or took the right remedies or medicines, but because I took everything to heart that I knew. I changed my approach to myself and the world around me. I said yes to help. I asked for help. I reached out for help. And I did what I could to feel better physically. So I'm part of what I learned from, and all the moms I've helped since then are the majority of what I learned from. Testing, scoring, and screening is an instrument, but it's the moms who teach us really what to do, what to look for, how to talk, how not to talk. I've made a zillion mistakes, so please feel free to join me. You'll make mistakes, and they'll tell you, I don't like when you said that, or they'll stop talking to you. Then you say, maybe that motivational interviewing went awry right there. What is the prevalence? This is hard to assess because women hide their symptoms. In England, they call this the smiling depression because it's so easy to hide. But what we do have in the research, postpartum depression occurs in 1 out of 8 new mothers. Think about your clients. At least 1 out of 8 of them. And if you have a majority of teen moms, how many of you would say more than half of your clients are teenagers? The rates go up to 26%. Military moms or military spouses, and we have both now, right? Women soldiers and wives of soldiers. The rates are up to 26 to 30% of military women. Moms of multiples, twins and triplets, also right around there. Antepartum depression or depression in pregnancy, who knew? It is just as high as it is postpartum. So how many of you are also seeing women when they're pregnant? When you're talking about the next question, preconception planning, and when you're talking about, when you ask someone, do you want to be pregnant in the next year? Put this into that part of your brain where you're saying, now I will also be asking about her emotions, and make sure mental health is part of the conversation. Then we're really going to prevent the most common complication and the crisis related to maternal mental health. If 1 out of 8 pregnant women has significant depression or anxiety during pregnancy, who is asking them? Because everyone's saying to them, isn't it great, such a beautiful time of your life, and you look fantastic. And then when women say, I don't feel good, oh yeah, pregnancy sucks. But really what's happening is that women are trying, they're hinting, they're saying, I don't feel good, I'm scared, I can't sleep. Oh, pregnancy, I remember my pregnancy was so hard to sleep. So we have to listen and listen and listen. Now, if we don't have time to listen, and we don't, you're not to blame for that. That's your schedule. That's where screening comes in. That's why you have this as part of a screen. Because screening detects more women than observation. That's research now. Postpartum psychosis is a different illness, and it occurs less often. 1 to 2 per 1,000 births. So at the end of the presentation is where I have more info about the different perinatal mood disorders. Those of you who've been to my trainings before know I always start with the types and symptoms and syndromes. But really what we're doing here today is talking about screening. So it's more like if we have time at the end, I'll talk more, to the extent we have time, I'll talk more about the signs and symptoms. But what's really important for you today is to know we're talking about screening. Are we talking about diagnosis or treatment or even a full assessment? Not so much. We're talking about screening to make sure that we know who might be at high risk for a perinatal mood disorder. And why do we screen? Because, for one thing, it's very, very hard for moms to tell people how they're doing. If you walk into a home and don't ask about her moods, her sleep, her appetite, her crying, do you think she is likely to tell you? Why isn't she going to tell you? When I think about the obstacles to care, I really, when I had postpartum depression, we didn't have a lot of research on medication in pregnancy and breastfeeding, and we didn't have a lot of websites, and we didn't have a lot of psychiatrists or therapists in Portland. I think I was the second who specialized. So, in Portland. I forgot to introduce myself. That's funny. Okay, whatever. I'm a therapist, and I'm an executive director of Postpartum Support International. There you go. Okay. So in my therapy practice, when I had it, we didn't have any of that. Now we do. Sometimes I actually think I'd be overwhelmed by the amount we have and the amount of options. If I were depressed and anxious, I would. We need helpers to guide and navigate. But still, with all of that, with the medicine we know, the research, the therapists, psychiatrists, Baby Blues Connection, Well Mama, Southern Oregon Healthcare Coalition, all of that, what's the single biggest obstacle, I still believe, is shame and fear. Because no matter what, if women are too embarrassed and ashamed that they feel bad when they have a new baby or when they're pregnant, they won't even make it to reaching out for help. And that's where you come in. We also have provider misinformation, cultural taboos, and accessibility to providers. So we're doing as much as we can to have are resources available in different languages, verbally, if people can't read, and to all socioeconomic groups. But it's hard. And do we have those providers? We don't. I am going to tell you what the resources are before we talk about screening, so you know that. But this is a big obstacle to care. Nevertheless, I still think this shame is the first and biggest. So, your name again?
Robin.
Robin asked me. She said a line of conversation that's been going on through this whole training is, what are the resources, right? If we screen, where do we send them? And that is the wonderful ethical question, and challenging, and it should be challenging to us. So I feel really fortunate that I actually know what to tell you. And that is that I am the executive director of, it's a large nonprofit with a very small staff. We're worldwide. We have volunteers in every state and in 36 countries. And how do we do that, you might wonder? Who knows? You've heard me talk before. Volunteers. We have about 200 volunteers, not counting our board members. Trained, informed, compassionate, non-judgmental, English and Spanish speaking. We also have Greek, Hungarian, and someone put down Latin, but I don't think she was telling, she's kidding. Anyway, so you can, from anywhere in Oregon or the world, call 1-800-944-4PPD, which is 4773, and that's a warm line. It's answered live 2 or 3 times a week, and it's otherwise a voicemail. People leave a message in English or Spanish, and a volunteer will call them back, usually within 2 or 3 hours, definitely by the end of the day. That volunteer will connect them with resources in their community. We also have educational DVDs produced in both English and Spanish, so that's something you can bring into the home and show there or leave with them. And we have once a week free Chat with an Expert phone forums for moms every Wednesday. Trained, licensed professional facilitates a chat group on the phone every single Wednesday and the first Monday of every month for dads. That's a great resource to have, because yeah, even if you don't know what else to tell her, you can say, you know what? This organization has free phone chats every Wednesday. So go to postpartum.net, the website. It's on every tab, really, but under resources, look for Chat with an Expert, and you'll see the schedule, the call-in times, and it's free and totally. How many people do you think are on those calls? 0 to 3 on average. Very underutilized, and our beautiful facilitators do it completely for free. We are developing them in Spanish as well, and I hope to be able to announce to all of you within the year that we have them in Spanish at least once a month.
Did you also say that you had a DVD, and is it available and is it free?
The DVD is not free. The DVD is one of the ways that we have some income at PSI. So it is, if you're a member of PSI, it's $40. If you're not, it's $50, but you can buy it in bulk. So if a center or clinic wanted to buy it, the more you buy, the less it is. And it's 13 minutes long. It's wonderful. So it's women who are interviewed, and that shows them with their babies. They talk about their symptoms and what helped. And then they have a couple of experts interviewed as well.
Is it in Spanish also?
English and in Spanish. They're 2 separate, yeah. We're so happy to have produced it in Spanish. That was just this year. So how many people have seen that DVD? Oh, it's so wonderful. Wonderful. Great. So what are the stats in Oregon? The PRAMS data says 1 in 4 moms reported, 1 in 4, twice as high, reported some depression during or after pregnancy. So everyone wants to know this, especially when you're working on the front lines like you guys, home visitors. I mean, you know every parent goes through an adjustment, and moms especially, so physical. So what's normal and what's not? Maybe in terms of resources and screening, maybe the most important thing I want to tell you about that is that if you're wondering or she's wondering, I'd say reach out. Because what I know about Postpartum Support International, Baby Blues Connection in Portland, Well Mama and Well Mama, Oregon, in Lane County and Corvallis. Klamath Falls has a support group. Deschutes is developing more and more support groups. But what I think is most important is that they don't need a diagnosis to call and get help and support. So if she's wondering, oh, I don't really know, is this normal? We get those calls, 50% of the calls to us say, I don't even know if I have it. As if you have to have like a ticket to get in, you know, to get support, and you don't. And I want you all to know that. If you're wondering, that would be normal for you to wonder, but to say, you know, if you have any questions about parenting, call this number, because this is a great place to get support, and maybe they can connect you with another resource if they aren't what you need. I just got a call yesterday from a woman who was from the Salem area, and she must have found our number perhaps on the brochure or the DVD, and she said, I need some information about how to help my baby sleep and eat better, because he's not sleeping and eating, I'm not sleeping and eating, I'm not feeling good. So of course I'm thinking, this is a holistic picture. But what got her to call wasn't, think about this for your clients, honey, I think you have postpartum depression, you should call PSI. Someone must have said to her, maybe it was one of you, I have no idea, you can call this number, because that someone said, I'm thinking she's having trouble, but I can get her to connect with help by saying, you can call and ask about your baby. And that's okay. We don't mind. We love that. Because by the time she calls, what do you think? He's not sleeping and eating. I'm not sleeping and eating. He's only 4 weeks old. I think she should be calling us, because she's worried enough, you can hear in her voice, and whoever was visiting with her knew that she's at least at risk. So even normal baby blues can be rough, but what we're talking about with depression and anxiety are true conditions. The stats, 1 out of 8, or in Oregon, 1 out of 4, it's more than the normal adjustment. How do we know diagnostically? Not that we're diagnosing here today, but how do we know is, the Diagnostic and Statistical Manual says if the symptoms persist longer than 2 weeks, and if they interfere with daily functioning. And that's the whole point about why Oregon, the home visiting grant, chose the PHQ-9, is it does correspond with those conditions. It has the element of longer than 2 weeks. I love that you have slinkies. I just noticed that. Longer than 2 weeks, and does it interfere with daily functioning. Do you all get slinkies?
We get different toys depending upon what table.
Do I get a toy if I do good? Because I like toys. How do we know who's at risk? There are risk factor checklists, but one of the best ways to know is to do a screen, a validated screen. And you got clay too? Or is it like Play-Doh? Has anyone ever seen this picture before? Deschutes County, I added this one a couple months ago. And you know why it's on the screen. Speaking of screens, you can't tell by looking. That's why we screen. So this woman, you walk into her house, you meet her in the hospital. How does she look? You know, if you were really using your observation, if an OB met her pediatrician, they'd say she's looking pretty good. She's dressed, the baby looks good, and got her hair done and makeup on and earrings even. Well, that woman about 3 weeks later killed herself. So that's a real picture, and a little bit I do it a little bit dramatically. I'm not that dramatic, but sometimes it's important to know, to be shocked, to say, oh my God, jumped in front of the L train in Chicago. And because this is who she is, did not know how to ask for help, did not know how to say I'm struggling, and wasn't observationally on a risk factor radar. Once a nursing student called me from OHSU, and she said, they started doing screens at the hospital. And I said, that's fantastic. And she said, but I have a question that I'm afraid to ask my supervisor. What's that? Shouldn't we be screening everybody? Because they said just screen the people who are at risk. What does that mean? That doesn't mean anything. We have to find out who's at risk by doing the screen. So they had chosen I shouldn't have said the name of the hospital because it was years ago and they've changed by now. So forget, whatever, PHQ-9 hospital. At that time, before they evolved and learned about screening and other things, so they were screening low income, high risk pregnancy, you know, the stuff. And that's not how we screen. We really we recommend universal screening. The challenge for us and what we're going to talk about today is how do we get through our own discomfort and barriers to do that? And why should it be universal? Because you can't tell by looking, because even with a screen, you will miss some. We want to cast a really broad net, just as you're learning with all the stuff this week. Is screening diagnostic? Actually, the PHQ-9 can be used to diagnose, but you are not asked to do that. Is that confusing, or does it make sense? A little of both? Okay. It's just a tool that can be used all the way from screening, learning, to diagnosing. So doctors like to use the PHQ-9 because it's diagnostic. It's not treatment. However, it is educational, because when you go through the questions, and they're in your handouts, it's really telling you, oh, you know, if you're having these symptoms, I have been feeling that. And as you're doing it, what we're going to talk about in this workshop is how you have that conversation where you're normalizing this and helping her realize that a lot of moms do have these symptoms. It does decrease risk because you're already connecting, you're opening up the conversation, and you're screening for who is at higher risk. And it decreases stigma because here you are introducing it to the conversation. So this is a really just one study. There are many, but I like this one because I got to make a cool chart. And this is in an OB clinic, the effect of screening versus non-screening. And what they've found in the last 10 years or so is when they ask OBs and pediatricians, do you screen for maternal depression? The majority of them in several studies said, yes, I do. And then they asked this brilliant follow-up question. What screening tool do you use? And they said, it went down to about like 12% actually used a screening tool. So while over 50%, yes, I screened, they didn't have a tool. What they meant is, I can tell who's depressed. So here in this study, over almost 400 outpatients in OB practice, they were screened with the Edinburgh Postnatal Depression Scale, and one that's used widely with postpartum depression. Using that screen, the rate of detection of depression of the women who were depressed is 35.4%. Spontaneously, it was 6.3. So that's just telling us how well women hide. It's not telling us how poorly doctors observe. I mean, if you ever have been to the doctor, you know, when you need help, you do want to tell your doctor, nurse, midwife, how you're feeling. There's no other illness I can think of except for addiction where you want to hide your symptoms. So how is a doctor, midwife, nurse supposed to, a home visitor, supposed to figure out who's feeling this when they're trying to hide it from you? And you know that women are. What are they afraid of? What do you think women tell us they're afraid of? I'm afraid to tell even my home visitor that I'm depressed. Why? I'll lose my baby. Bad mother. What else? What? She might tell my mother-in-law.
Just fear of judgment.
Fear of judgment.
Culture.
We're not supposed to tell people outside the family. My husband told me not to tell. This is what we hear. So, on the other hand, that's why. Why home visiting? Why do I think, and I do, this is perfect. You are the perfect people to be doing this screen. Because there's a comfort. There's a comfort with you. You're in there in the home, and it's just a little harder to hide, you know. The setting is something that she can be in, and that just feels different. That feels different to all of us. Maybe most importantly are the barriers that people have to even getting to a provider's office. You know, that, of course, that I'm preaching to the choir about that, but just to be able to come to somebody. Also this, you really are poised to facilitate connection referral. You just need to know what they are, you know. And right there, you are in the mode and have the ability and the way that you present to families to, while you're screening, to educate and reassure them. And that's, as you can hear, for me, maybe the most important part is how you do that, the warm part of the warm handoff, you know. You can also, in your assessment, in your big picture view, you can get a picture of how the home feels, how it looks. And honestly, and you've heard me say this if you've been to my trainings before, if the home is too clean, to me, that's on the list of things to watch for as a risk factor. I mean, the home should not be that clean at 2 weeks postpartum, unless you are living with a very clean mother-in-law or partner or sister. But the mommy should not, there's something a little bit in the natural world off about having things, spending too much time on cleaning and getting your body pretty and skinny and your house spick and span. So she might actually be anxious and cleaning more than she should be to be healthy. That's all intro. So what is the PHQ-9? A couple slides that's just going to tell you what it is and what's on it, and then we'll get to use it. PHQ is the Patient Health Questionnaire. It was developed for medical providers. It's a wonderful tool when you think about it. So primary care providers said, we need something to address mental health. And the PHQ covers everything, anxiety and sleep disorders and addiction and depression. What someone did is take the PHQ-9 just to focus in on depression. So it's self-administered questionnaire. It should take, they always say this, but then I don't know why I added on my slide just because everyone says it, but it could take 5 to 10, it could take 20, and it could take 2. But on average, it should take 5 to 10. I just think it's a little bit frustrating because if someone has trouble reading or they're depressed and trouble figuring out what that question means, it will take her longer. So that's also in a way part of your assessment, but if you just look at it and once you give the instructions, you know, what their job is to check off what they're feeling. It should be quick if in fact the reading comes quick, but you guys know what I mean. How many of you know what it's okay if you don't, Diagnostic and Statistical Manual is? Great. So what that is kind of the Bible of psychiatry. In other words, a bunch of people get together every so often and they have big committees and they come up with different diagnoses all across the board that can be coded for psychiatry and mental health treatment. They're coming up with a new one right now, the DSM-5. So this DSM is the origin of these questions. In other words, if you look at the DSM under depression, major or minor, they will have these exact symptoms. And that's why people like it to use for screening. You can also use short form, which is the PHQ-2, and I know that the Nurse Family Partnership already uses this. So how many of you are already familiar, or how many of you use the PHQ-2 with your families? Anybody here? And has anyone ever heard of PHQ-4? I know. If you just stay around long enough, everything is created. But the PHQ-4 also addresses, it's 2 for questions about depression and 2 for anxiety. So in other words, the first 2 questions, I know it's on another slide and I'm jumping ahead, are the PHQ-2. That's it. And you've probably seen them everywhere. Have you had, in the last 2 weeks, now that we've confirmed that, 1, little interest or pleasure in doing things? How often? Number 2, have you been feeling down, depressed, or hopeless? That's the quick screen. And the research is really good on that screen really being pretty effective for screening for depression. Doctors really like it, and a lot of doctors' offices, and I think that the Nurse Family Partnership was using it this way too. No, is that they do the PHQ-2, and then if people screen positive, then they do the PHQ-9. In the START trainings, pediatricians training pediatricians in Oregon, they recommend using the PHQ-2, and if they screen positive, using the Edinburgh Postnatal Depression Scale. So. That I just wanted to see how many people were already familiar. And does anyone here already use the PHQ-9 with families? You do? And you do? In what setting do you use it?
Our primary care clinic.
Primary care clinic. Where is that? Tacoma? Tillamook. Oh, wonderful. Great. And you, Albina?
Yeah, Albina. Our nurse does it when she does the postpartum visits.
Great.
So were
Good.
you saying they do the 9 and then the Edinburgh? Is that what I just heard?
The START trainings, that's what the pediatricians do, the 2 and then the Edinburgh is what I meant to say.
Oh, okay,
Yeah.
thank you.
Do all the providers in your clinic use the PHQ-9, or are you one person using it? Or?
No, for providers.
Great. And
I'm just curious, you said that they do the PHQ-2 first and then follow up with the other, but aren't the first 2 questions sometimes limiting to a lot of people who may be depressed and hide it in all those other ways?
yes, in fact, which is why I'm guessing. I wasn't in on the process of deciding to use the PHQ-9 for this grant, but I'm guessing that's pretty much what the process was, is that they wanted to not miss people by only doing the 2. Is that right? So, excellent question. Yeah. Good thinking. So, what do we have? In your, right after the PowerPoint, you can see you have handouts specific to this presentation. And I think what would be helpful right now is to look at the one that just has non-scored, no colors on it. Or you can look at the scored one, that's fine. Just don't, I'm not using the one with colors on it quite yet. And so you see there are 9 items, and then a 10th one is added to talk about how difficult these symptoms have been for you. But the first 9, each one of those items is to be scored from 0 to 3. 0 being not at all, to 3 almost every day, or literally nearly every day. So because of that, this is a screen that can tell you about severity. And the severity then can be anywhere from 0 to 27. Clearly, I don't know if a new mom would score 0, because of the normal adjustment to parenthood. In fact, I might kind of scratch my head at that, a little like Columbo. One more thing, ma'am. Is there anything else you want to tell me? So, to 27, where that's an absolute emergency, we need help, stat. So, I'm speaking a little slower because I have 2 sides of my brain, as you all do, and the side of me that presents is not actually, see, I always have to think about this. Anyway, it's not my rational side. I just need to say that. I have learned all this stuff, but then when I'm speaking, it's intuitive. And so when I have to slow down, I'm not doing it for you because I'm condescending. I have to slow down because I have to wake up the part of my brain that uses numbers. That would be the left side. And so that's what I'm doing. And I'm just, for full disclosure, that's what you're seeing. Because now I'm like, okay, we're getting to the arithmetic part, Wendy. Come on. Okay, now. So 0 to 27. And if any of you feel like that too, then we're, buddies. What does it measure? It measures a couple of different things. First, it measures the number of symptoms, right? So you have 9 choices here, and it measures how many of the symptoms you have. But it also measures the severity. It measures the level of functional impairment, and that's question 10. And question 9, really important, big red flag, is suicide risk. So if anyone answers anything besides 0 on question 9, you have to follow up. There is no question about that. So let's just go through these one at a time. When you're talking about the number of symptoms she has, the question, if you look at the very first instruction on it, it really is over the last 2 weeks. And you can, when you're doing an assessment for someone, you can make that assessment read any way you want. You can ask about the last month or the last 3 months, because maybe that's what you're assessing. But what's really important for us in using these screens is to see what was used in making it evidence-based. And so that's what that conversation was, and really important to have. It's not that asking about the last month is a bad assessment. It's a great assessment. It just won't line up with the numbers in the same way, and that's what they were talking about and why that was so valuable. So we're really talking about in the last 2 weeks. And when you're starting to present this to moms, sometimes people actually forget that. It's not easy to forget it, but we really want to emphasize it for a couple reasons. One is that's the validation, but also how many of you, even just having regular surgery, but certainly when you're a new mom, even without depression, you know how time is weird. And if you you have to give her a minute to think about the last 2 weeks. Do you know what I mean? So in the last 2 weeks, let's say 2 weekends ago or 2 Wednesdays ago, like help her orient her. Have you been bothered by any of the following problems? That's the question that gets at the number of symptoms. We're going to return to this. So I don't know if this is technically an adult learning approach, but it is for me, this adult. I'm going to say this, and in about 3 slides I'll say it again, so you don't have to work that hard to remember, okay? So when you were talking about scoring and you're looking at the numbers, you're going to count the answers only in the last 2 columns. That's where it starts to get into, this is the tool it is. And that's where people start to go, oh no, that's complicated now. Can't we just add what it is? So what I'm entering into is telling you how this tool has been scored and validated is we're looking at depression, we're really only counting the last 2 columns. Why is that? Think back to the DSM. Longer than 2 weeks. So what we want is more than half the days. We don't want to scoop up all the moms having trouble with some forgetfulness, fatigue, depression, anxiety, trouble sleeping, trouble eating, because they're all tired. And you would end up with so many people getting referred to your poor nurse or whoever it is in your system, or you, that it wouldn't make any sense to you at all. Or you'd get different numbers from one part of the county to the other. So when they do the scoring, they are looking at just in the last 2 columns. Now that's number of symptoms. The second part that this screen shows is severity. And depending on your agency and what you all decide, you may or may not use that information specifically, but it's always interesting and important. And it really does pull up something that's very hard to assess, even for me as a therapist. If I don't have an objective way of asking someone, in other words, just how bad is it, I'll miss it. I will. Because we all want to be better. We all want to look good and feel good. It isn't just pride, it's like desire. So it's really important to say what's the severity. And this is something I'll come back to again in 5 slides. So then the third part, right, is question 10. And that's the level of functional impairment that comes from the DSM language. And the question is phrased, if you checked off, for some reason they underlined. So that's also, when I look through all these things you can download, that varies in different downloads. And I think if you're doing a screen, that's probably important. So people who are deciding what screen to use with home visitors, I think you should decide whether you use the underlined version or not. That sounds so trivial, but I'm sure we could talk about it for hours. If you checked off any, I took this from the people who created the PHQ. If you checked off any problem on this questionnaire so far, how difficult have these problems made it for you to do your work, take care of things at home, or get along with other people. And if I were saying this verbally to someone, if they didn't read, I would pause at the commas. And if I were having someone fill it out for themselves, I would say, what? Take your time. Because we want them to take in, this is a complex question, really. Have you ever, don't raise your hand, but if you've ever been depressed or anxious, it's really hard. Like, that's a lot of language. I'm just saying the truth here. So tell them, take your time, absorb it. And if I were reading it, I would really pause just like I did. This is the picture for this slide. Because I just thought, like, oh yeah, do your work, take care of things at home, or get along with other people. Yes, indeed. That could be normal mommy. No depression, no anxiety. And still, how do we not? That's my question. How do mamas not have some difficulty doing their work, taking care of things at home, or getting along with other people? So the question is just how difficult. And when you look at question 10, you can see not difficult, somewhat, very difficult, or extremely difficult. Going back to the harder part to really address in many ways as home visitors is, what do you do with question 9, or in some versions it's question I. Thought that you would be better off dead or hurting yourself in some way. So we will come back to what you can do as home visitors, but I'm just trying to give you the format of what, and kind of as you read along, what the screen looks like. So it's been validated to measure depression severity. It is validated to be used in English and Spanish, and it's also validated to be used over the phone. So I don't know, do any of you already do screening over the phone? Any kind? And where do you do that? At Tillamook? Awesome. What is it? Are you at the same clinic, or are you different places?
Yeah.
What's the clinic there?
No, we're not at a clinic. We're at Healthy Start.
Healthy Start. And what's the clinic you're at?
Health Department.
Health Department. Great. So it's free to download. And this was something that I actually didn't know about till I was getting ready for this. So I was so excited. You can go to PHQ-screeners.com and look at all the languages it's been translated to.
We've used it. It's
Yeah, good.
Yeah.
They must have used, real translators, real language. And they talk about that on the site, the PHQ-screeners.com. You can tell, if you go to that, and just go because it's interesting, that they talk about that it's not just literal translations, but really making it culturally accurate as much as possible. And please tell us if we made mistakes, or if you want to translate one. It is important to know, in case it's necessary to know, that if they're not validated, all of them, but they are available. And have you used a bunch of them, or?
We use Chinese, and then I wanted to say like Guatemala or something. I don't know.
And that was also fascinating. Many different versions of Spanish and of Chinese. So I know that women really appreciate that. And the more, if you can take a screen or talk to someone in your native language, of course it's easier. But so this is good, and I just put in the quote so you could see it. Translations are downloadable from the website. No permission is required to reproduce. But they want you to, they say, but let us know. And there's also articles and bibliography. So I was really pleased to see this, and in quite how many languages they have. And because they ask for people to contribute, there will be more and more. The next part is screening times. Now, there might be some variety in the different agencies here, and I don't know whether there is or not, so please ask yourself if you're the person in charge of making that decision. But I sure love this picture. So, off the top of your head, I mean, what do you think? When should we screen? People have different opinions about that, but I mean, does anybody, when do you think the first screen should be?
First contact.
Excellent. 2 questions, both sides of the room. First contact, why not? In fact, a lot of people talk about doing preconception screening before pregnancy, because that, just to get a baseline. But certainly, why not at intake? Oh, look at that. Second, these are recommendations that come from the PHQ, and as I said, I don't know if you guys have different ones, so I just put what I have here. I would say earlier in pregnancy, but this is 36 weeks for sure prenatal, and postpartum, the recommendation is sometime between 1 and 4 weeks, sometime between 4 and 6 months, and then another one is at 2 months. These are coming from 2 different places. I think, and most importantly for home visitors, this is why I love that it's you guys doing this. Who is seeing a mom? If postpartum depression can start right at childbirth, peaks at 3 weeks postpartum statistically. Who is seeing her? You are. Doulas, maybe, postpartum doulas, if she's fortunate enough to be able to connect with one. And maybe she sees the pediatrician at 2 weeks. But for many women, they have no symptoms at 2 weeks. They don't have symptoms yet. So a lot of women don't get any symptoms until 3 or 4 weeks. So this is really important to know, and I really like that early screening. Now we got to move into how do you do the screen. The first part is introducing it, and you will have a chance to practice this, but I'm just going to give you a couple of ways perhaps that might be helpful. I'm going to go through this slide first. First, you introduce it, right? Second, you administer it, you score it, you discuss it, and you refer. And each of the agencies involved in this training has asked that that's what you all do. So I added that, I think. No, I think it was agreed with. There was consensus that encouraged should be there. And having some kind of warm handoff. So when you look at all that, I know you're doing this with a lot of screens, and I just want you to know that I just really appreciate what you all are taking in these days, and that the fact that you're doing it and learning it, and so I just needed to say that. I'll say it again, I'm sure. I just think you've probably got this with all the screening, and with this, I hope you feel comfortable by the end just knowing, okay, this is a screen that is meant to help her. It's meant to be a little bit of a life jacket or a life preserver. It's not meant to be a test, and it's not meant to be a test for you. It gives you language to say, let's talk about depression because it's really common. I added these following up with the referral and following up with client, especially if you see on the severity that she really is in trouble. This is just really important, whether you do it or you can ask somebody else who works with you to do it. This is the challenge, and because of the taboo of maternal depression and anxiety, it really is challenging but this is our goal, to create a safe conversation to have this. Now, I know that every one of these screens, you're talking about how you might use motivational interviewing in the screen. Our challenge with this one is that we're not talking about intervention, so it's not that kind of motivational interviewing where now we've figured out that you've got this going on, we're going to help you figure out what to do next. And so still, you can build in what you already know about motivational interviewing into how you introduce, going back to the last screen, administer, score, discuss, and refer and encourage. Does that make sense? I like this picture because she looks, motivated and inspired and confident, but not exactly exuberant. What part of motivational interviewing, and we'll have examples of this. First of all, you're collaborating with her. You are there as her ally. So as you've learned with motivational interviewing, that kind of non-judgmental listening is so important with so many of these topics. In maternal depression, as you were saying, why don't people tell? Because they're afraid you'll judge them. And they're watching and listening. So it's women who have postpartum depression are exquisitely sensitive to the kind of comments like, well, but he's healthy, or you've got everything here, honey. Even when you're trying to be compassionate, if you say, you've got everything you need, there's no reason for you to be depressed. Is that judgmental? Even when you say things like, oh yeah, I know some women just have a harder time than others. See, that might sound like really compassionate, but for me, when people said that to me, I did not feel like that was compassionate. I felt like, I'm one of them. Some women just have a harder time than others. Many people said to me, Wendy, some people just don't like the baby stage. I didn't like that. I was trying to like it. I like it now. So much easier from the outside. I'm not depressed. But he won't let me rock him. No, just kidding. Motivational interviewing. How do you draw out her ideas when she doesn't want to tell you? You do it by saying, a lot of moms feel depressed and anxious during pregnancy and postpartum. How's it going for you? Classic MI technique built into this. A lot of moms feel this. Tell me how it's going for you. This is so important, right? Now, my take on motivational interviewing is all on the compassion side, because I get kind of sketchy and scared about, like, we got to motivate. The more you read about, like, into addiction theory and motivational interviewing, it's more like resistance and getting through that. And this is a different kind of resistance. This is resistance based on shame and fear, which also addiction is, but it's really not so much about her not wanting to change. It's that she doesn't have the language, the words, or know that you can hear it. So in all motivational interviewing, one of the most important things is encourage the step they're at, right? Where is she? Even if the step is little, even if she just told you and you're the first person she told how she's feeling, excellent. You really encourage it. Thank you so much for telling me how you're feeling. Let's talk about the first step you can take so that you can feel better, because you deserve to feel better. And one key motivational interviewing technique, for example, is to say, you've been working so hard on la 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 la, let's see what we can do next. So think about how that would sound to a new mother. You've been working so hard and taking care of your baby and yourself and your house and your kid. Let's see what we can do to help you feel better. See, that works. Supporting her self-sufficiency, including what is the most important role of self-sufficiency for a new mommy. It's ironic. I'll give you a hint. Learning to ask for help. It's like a joke. Women at high risk for postpartum depression are the women who are the most self-sufficient, the high achievers, overachievers, perfectionists. They don't know how to ask for help. So when you're talking about self-sufficiency with these women, what they need to learn is how to say, yes, I need that. I could use some help. I do want to talk to you. I would love if you could stay 10 more minutes. I would love to see you next week. Any of that. So that's a funny take on self-sufficiency. And understanding what are her fears, not what we think her fears are. What are her fears? Really listening, really using your ears and your heart to listen. What are her fears? What are her concerns? Do you all use this acronym, OARS? How many of you know OARS? Okay. It's a part of the approach to use compassionate, non-judgmental motivational interviewing. And I learned more about it through doing the WIC seminars that we did, webinars that we did last month. O is for open-ended questions, not, are you depressed? That's a closed question, yes or no. So open-ended question is not a yes or no answer, and it would be, do you have any questions for me about depression? Affirmations, recognizing her strengths. Oh, look at how you can cuddle both those babies at the same time. I mean, who's saying this to her? And you might think, oh, she doesn't need me saying that stuff to her. But if she's depressed and anxious, she really, truly does. My doula used to say to my husband, you need to know she walks around with this negative tape in her head all the time. right now that doesn't seem like all that like mysterious, but at the time I thought she was a magician for knowing that. I couldn't believe she knew it. And did I mention I was a therapist for 14 years? I like forgot everything I knew. I didn't even know I had depression. I just thought I wasn't a good mom. I wasn't in the club and I should be kicked out. I really did. But my doula said to my husband, she's got a negative tape about herself in her head all the time. Anything you say that is kind will help her. And I remember sitting at the table going, how does she do it? It's not really, it's mysterious. I just didn't think anyone knew. And so it's true. And anything you say, just like, oh, look how that baby looks at you when you talk to him. Look how he turns to your voice. Affirming that just waking up and feeding the baby and taking care of herself really is an important thing she's doing. The R in the ORS is reflection. So she says to you, I have been having a hard time, actually. You don't say, well, you know it's hard for everybody, or you look good. You say, oh, I really hear that you've been having a hard time. That's the simplest way to put it. Maybe it sounds artificial to you, like, oh, she'll know totally, I learned that at a training. But she's not thinking that. And neither will your sister or your partner, I swear. They won't think, oh, she picked that up, whatever. No, they'll say, yeah, I do. Because, well, here's another aside. Do you know how we always say men like to solve problems and they just don't listen? They just want to go right to the solution. Well, come on, really? Who does that? We do that. Women do that, right? Right, Tom? We do that. Come home and talk about work. You said what to him? I mean, I am always jumping to the solution. It's okay if you don't want to admit it, but I am admitting I am always jumping to the solution, and then I think, what am I doing? I'm supposed to have empathic, reflective listening, even though I spent 8 hours doing that for all my clients. I'm supposed to say, that sounds really hard. That was a hard conversation. So we do that, and that's motivational interviewing number 1. Don't jump to the solution. Don't fix it. And honey, you are going to want to fix it. As soon as you do a screen and you find out she's depressed, you're going to want to fix it. And take enough time to take 1 minute to not fix it. Because the first step of fixing it is hearing it. And don't make up what she's saying to you. Hear what she's saying. She says, I haven't slept for 3 days. And you start to freak out and want to tell her how to sleep. Take a breath and say, you haven't slept for 3 days. How are you feeling? And when she says how she's feeling, say, wow, I really hear how hard that is. Have you told anyone else? So that's where we start. Then we can go to fix it. And then the summary. So in summary, and you can do this in all different ways. There's lots of ways to do that. What I hear today is what we've gone over. And then, part of summary in this model is the action steps. What will we do next? I thought perhaps we'd do a couple of conversation tips before we practice with the scoring. Some of these are tips, that I made up, and some of them are from the Edinburgh Postnatal Depression Scale instructions. Some are from the wonderful Registered Nurses Association of Ontario has a great write-up about ways to introduce these kinds of screens. So here's one that is in the beginning of the Edinburgh, and it says, having had a new baby can be very difficult. The questions here are here to help you assess how you're feeling. I really love this kind of thing, is when you're introducing it, and you can say, this is a questionnaire that we give to all our families, all our moms. Sometimes this questionnaire gives new moms new words to describe how they're feeling. And I actually got that off of a PHQ article, and I think it's really simple and brilliant, because it's saying to her, it's kind of motivational in itself. We find that sometimes this questionnaire itself gives moms new words to describe how they're feeling, as maybe you couldn't describe it. Then it kind of becomes something that's helpful instead of something that's oppressive or scary. And it's actually true. You see a mom look at this kind of screen and go, I actually have been feeling that, and not even having the words to say that. And then you might say, sometimes moms find having new ways to describe their feelings helps them talk, see that hint in there, talk to their providers or their families. And it's also true. So I thought it might be fun, but I don't know if you think it would be fun or if we'd have time, but to break up and do the things you shouldn't say, because
That would be fun.
you don't look that good. And we have a test for that, because we don't want anything bad to happen around here, and I saw how your husband's looking at you, so I'm a little freaked out now. Will you take the test? I'm going to stand right over here while you do it. That is not how to do it. Right? Any part of that, we give any part that makes her feel, we give this to women that look bad. Never saw that score before. Wow. You know, so I did support a woman who told me, for example, it's always hard to do because I'm going to poignant after laughing, but that she went to the hospital, and in the questionnaire, this hospital was wonderful enough to ask her not only about her mental health, but about her risk factors and history of abuse or rape. And she said, yes, I have been raped. And the nurse said to her, whoa, no one ever answered yes to that before. What are we thinking? And she went, oh, because she was there to give birth. And so I've heard people say things like, to postpartum women, oh gosh, you know, I just never knew anybody who didn't sleep for that long. And I heard that could drive you crazy. No. But when we're preparing for screening, we want her to feel what? This is a screen for depression. Doesn't diagnose, it just tells us who might be at risk for depression. This is a simple way to understand. If there's something, isn't this language, not mine, I like it. I don't think it's mine anyway. This is a simple way to understand if there's something going on that's a little bit unusual from the way you usually feel. So really, what is that called? Normalizing. And you know, if you've been to my trainings, that these are my words. We use this with everyone we visit. And not because we think you look bad or depressed or we saw how your husband looked at you, but because we want our moms to get all the care they need, and we want to find out if there's anything going on unusual from how you usually feel, or making it difficult for you to really feel healthy and good and supported as a mom. Everyone in our program gets a screening, and that will be true, right? So that's the sample lead-in that was similar to the one before. This is directly from the Edinburgh, actually, but you can borrow it for the PHQ-9. It's not easy being a new mother, and it's okay to feel unhappy at times. As you've recently had a new baby, we'd like to know how you're feeling. Very straightforward. And then when you're getting into the instructions, please check the answer that comes as close to how you have felt. It doesn't have to be exact, and that's for women who get very literal and concrete, especially when they're depressed. And I've done that before in other questionnaires where people just like, well, I don't know if it's half the days or every day, and so you just want to say, even before you start, and you might say as a prompt while they're going, it's okay, just check what's closest to how you feel in the last 2 weeks, not just today.